All right, you guys, so we're gonna jump right into pulmonary vasculature. Here we're gonna do kind of an overview of what's going in. Then we're gonna spend a lot of time talking about pulmonary circulation, how it works, what it does, what its functions are, what happens when it becomes dysfunctional. We're gonna spend a little bit of time on bronchial circulation. Then we're gonna finish up with the respiratory zones and the neurological or the neuro components with breathing. We're not gonna deep dive into the neuro components, but just a surface level. We'll dive in further with the neuro component in later sections with ventilation. But when we talk about pulmonary circulation is moving from the right side of the heart to the lungs. The blood flow moving from the right side of the heart to the lungs so that external respiration can happen. You get the exchange of oxygen for carbon dioxide. When we look at bronchial circulation, this is the blood flow that it takes to, this is the blood flow to supply nutrients, oxygen to the trachea, the conducting zones, and to the parenchyma of the lungs. So we'll talk about that. We've been hitting that in some of the other videos, so we won't spend a whole lot of time on it. I'm going to spend a whole lot more time with pulmonary circulation. And we'll finish up with the nervous system. So a good comprehensive look at what's going on here when it comes to pulmonary circulation. So when we look at pulmonary circulation, we have to understand that we're trying to get the deoxygenated blood from the right side of the heart to the pulmonary vasculature, to the pulmonary capillaries, so that external respiration can take place. So we have to kind of run through the blood flow of the heart. You have the superior vena cava or the inferior vena cava that goes into the right atrium, that goes into the tricuspid, that goes into the right ventricle, that moves into the pulmonary, the pulmonic valve, into the pulmonary artery, that then gets to the pulmonary capillaries for gas exchange. When we look at the blood flow, we have to understand, we have to appreciate, we have to know this blood flow. But what we're trying to do is get this deoxygenated blood from the right side of the heart over to the pulmonary capillaries or the lungs so that it can oxygenate that blood. Once that happens, then we can start to get more oxygenated blood from the lungs, from the pulmonary capillaries, back over here to the left side of the heart so that it can go back out into systemic circulation. When we look at pulmonary circulation, the vasculature, the veins and the arteries, they really follow the right and the left mainstem bronchi. Then they go through the hilum. They go into the different generations so that they can then supply blood down to the respiratory zone, into the respiratory bronchioles, the acini, and the alveoli. When we look at pulmonary circulation, there's two different types. There's two different types of arteries. You have the conventional arteries, and these are the ones that kind of follow the path of that branching or those generations with the airways. And then there's supernumerary, and these are arteries that kind of split off at a 90-degree angle that go out into the periphery of the lung fields. So they go to supply other areas besides the pulmonary vasculature down in the alveoli for gas exchange. When we look at the pulmonary capillaries, we get that blood supply from the pulmonary artery, that's deoxygenated. It'll go through arterioles. From the arterioles, it'll break down into the pulmonary or the alveolar capillaries. With the alveolar or the pulmonary capillaries, these will hold about 60 to 80 mLs worth of blood. But what's great about them is they can engorge, they can swell. They can swell to be about 200 mLs in those pulmonary capillaries. Now, when we look at those pulmonary capillaries and they begin to swell, when would those pulmonary capillaries get engorged? Whether they're sick or a healthy patient, what would lead to needing more blood supply to the pulmonary capillaries to get more oxygen in or to get more carbon dioxide? Think about that. What would lead to more volume being needed in the pulmonary capillaries? And those pulmonary capillaries, they can engorge to be about 200 mLs. So they go from 60 to 80 mLs worth of blood all the way up to 200 mLs worth of blood. And that's a lot of volume that can go across the billions and billions of alveoli that are in the lungs. Once they go from the pulmonary capillaries or these alveolar capillaries, they go out the venules and then they go out the pulmonary veins. Now we have 4 pulmonary veins. On that last slide, we talked about the blood flow from the right side of the heart. Now when the blood gets to the left side of the heart, it's going to come back in through the pulmonary veins. We're going to have the blood come back in through the pulmonary veins, and there's 4 of those, 4 pulmonary veins. Then it's going to go into the left atrium, go through the mitral valve or the bicuspid valve, go into the left ventricle. From the left ventricle, it's going to go through the aortic valve. From there, it's going to go into the aorta, and then out into systemic circulation. So you have to understand, you have to know that blood flow from the right side of the heart to the lungs, and then from the lungs or the pulmonary capillaries, these alveolar capillaries, into the left side of the heart and then out into the body. So we have to understand and we have to appreciate that blood flow. Now there are 6 different functions when it comes to the pulmonary blood flow. And what we have there is it's delivering deoxygenated blood to the pulmonary capillaries so that it can exchange carbon dioxide for oxygen. So it's going to deliver deoxygenated blood to the pulmonary capillaries so that we can have gas exchange. When we look at the additional functions of the pulmonary capillaries or the pulmonary circulation, we have barriers. So when we have these barriers, we have the alveolus that's got the pulmonary capillaries sitting around it, and there is a barrier from the blood between the interstitial space, the alveolar unit itself. So the pulmonary capillaries, they actually are a barrier for the interstitial space and the alveoli. So it creates a barrier for those 2 units. When we look at it being a reservoir is a place where it can hold a lot of blood, or it holds volume of something. So this reservoir, remember we said that these are 60 to 80 mLs worth of volume in that, and that can increase as much as about 200 mLs. So that's a lot of volume that the body can hold in the pulmonary vasculature. Remember when we talked about the gas exchange units and the size of them, when we spread out all of the AC membrane, it actually can cover a tennis court. So there's a ton of space for blood to collect as a reservoir. Now, it can be used as a filter as well. When we look at the filtration, when we look at the size of the pulmonary capillaries, these things are 7 to 10 micrometers big. Those are teeny tiny, they're microscopic. Hemoglobin and red blood cells have to actually get in a single file line to get through from one side of the pulmonary capillary to the other. So there's not a lot of foreign particles that can pass through those pulmonary capillaries. If there's any sort of blood clot or foreign particles, those do not get to pass through because they simply will not fit when it comes to the size of those pulmonary capillaries. When we look at the pulmonary capillaries' ability to convert, or their conversion factor, they can take angiotensin type 1 and convert it into angiotensin type 2. And this becomes really important when we're talking about the RAS system. And we see the RAS system when we have patients that have hypovolemia or they're in a state of shock. We see that the RAS system will kick in to help boost that blood pressure. We'll talk about the RAS system in future talks. And the last thing is we have an inflammatory response. So when the lungs get irritated, they send out cytokines, and that release of cytokines starts to send out inflammatory response markers so that we can get the immune system involved with whatever is causing that irritation. So we have a number of different functions when it comes to the pulmonary circulation. So this is probably my favorite here, is when things start to get dysfunctional. Why does it matter that I need to know about the pulmonary circulation so much? So when we look at pulmonary circulation, if we were to look at the mitral valve, or we were to look at the left ventricle here, if we were to look at either one of those, and let's say that there was a dysfunction of the mitral valve. So we have mitral valve stenosis. So when we talk about mitral valve stenosis, what this is this is a stiffening, this is a hardening of that mitral valve. It is not going to want to open up and allow blood flow through the mitral valve nearly as freely as something that has nice and fluid and is not as rigid. So if we have mitral valve stenosis, if you go back and you look at the blood flow from the left side of the heart out to systemic circulation, but if we kind of walk that backwards, if we walk that backwards from mitral valve stenosis, this valve right here is not functioning the way that it's supposed to. So it will start to not allow blood to move from the left atrium into the left ventricle. So we have mitral valve stenosis that leads to left atrial filling that exceeds the capacity of that left atrium. So we get left atrium kind of overflow or spillage. So we get blood that backs up in the left atrium. From the left atrium, it's going to back up into the pulmonary veins. From the pulmonary veins, it's going to back up into the venules, which will then eventually back up into the pulmonary capillaries or the alveolar capillaries. Remember, those things can engorge and they have a lot of flexibility that allows them to take on a whole lot more fluid. But once those pulmonary capillaries cannot keep up with, or they exceed their capacity, we're going to start to see those pulmonary capillaries. This is going to be an engorged one. We're going to see those pulmonary capillaries start to spill that fluid over. So that fluid is going to fall into the tight interstitium. So it's going to move into the interstitium. So that will then spill over into the alveolus. So then we have fluid in the alveolus. So when we get fluid in the alveolus, we start to get all of this fluid here. We call that pulmonary edema. Now, when we have pulmonary edema, it is a surplus of fluid that the pulmonary vasculature cannot deal with. So when we look at pulmonary edema, it is an excessive amount of fluid that moves into the interstitium and into the alveoli. So when we look at patients that have pulmonary edema, where might that fluid settle? Well, it depends on the patient's positioning. If they're sitting upright, that fluid's going to fall to the bases. If that patient is supine, then all of that fluid is going to move to the posterior, the dorsal region of the lungs. So that's important when we talk about pulmonary edema, because if I lay that patient down, now it's taking up a whole lot more surface area of the lungs versus having them sit straight up. What do we call that? What is that medical term when patients become short of breath when they lay down? Also, when we have pulmonary edema, this can lead to a couple of different breath sounds. We can have fine crackles, we can have these cardiac wheezes, we can have late end inspiratory fine crackles, lots of different breath sounds that can be associated with this. The question is, what is your recommendation going to be when you hear pulmonary edema? The recommendation should be CPAP 10 to 12, Lasix or a diuretic, and then lastly, nitrates if your patient can tolerate it. What do I mean by if the patient can tolerate it? Well, you need to look at the patient's blood pressure and you need to calculate that MAP, the mean arterial pressure. If you have a mean arterial pressure that's really low, then you don't want to give a nitrate which will vasodilate. That will drop your blood pressure even more. So if your patient's blood pressure can handle it, you want to give the nitrates. And then you want to give that patient Lasix, And then lastly, you want to get that patient started on some CPAP. Now, one of the questions that I always love to ask is when we add CPAP to this pulmonary edema patient, if I have, let me get my pen going. If I have this patient with an alveolus that's full of fluid and I add CPAP to that airway, I'm going to get a little bit bigger alveolar duct, and my alveolus is going to get bigger because I'm adding positive pressure to it. Now, I didn't force any of that fluid out. But when I look at the pulmonary circulation, I only have a small area right here where I have gas exchange taking place. But whenever I add positive pressure, I make that alveolus a little bit bigger. I widen the alveolar duct. Now look at how much room I have for gas exchange versus that tiny area there. So when we look at using positive pressure, or we look at using CPAP for these pulmonary edema patients, it's not the water being forced out by that positive pressure. What you're doing is you're increasing the surface area of the alveolus itself, which then gives you more room for gas exchange. So I really like talking about dysfunction when it comes to the pulmonary circulation. Ooh, the zones, the pulmonary zones, these respiratory zones. This can be a difficult concept to understand, but I'm going to try to do my best to break it down here. So when we look at zone one, if I were to draw a lung here, we have zone 1 at the top and we have zone 3 at the bottom. So zone 1, zone 2, and zone 3. So zone 1, when we look at the size of the alveoli in zone 1, they're going to be a little bit larger than the alveoli in zone 3. And that's because of gravity. You have more blood flow going to the bottom of the lungs because gravity is going to bring water down and it's going to bring air to the top. The other thing that happens is you have all of the weight of the lung itself sitting down here in zone 3 versus very little weight sitting up there in zone 1. So you have alveoli that are a little bit bigger in zone 1 than they are in zone 3. So if I have all of this extra pulmonary circulation, all of this blood flow that's impacting the zone 3, then those alveoli are actually more likely to collapse. So if I were to listen to a patient and they had fluid overload or the pulmonary capillaries got overwhelmed, then where am I most likely going to hear those fine crackles? Right, most likely I'm going to hear those in zone 3. Now I'm not saying that they can't get to zone 2 or they can't get to zone 1, but when we have patients with pulmonary edema, most likely we're going to hear that beginning in zone 3. When we look at the alveolar pressure, we have a higher pressure of alveolar oxygen than we do arterial oxygen. So what that means is we're going to have an increase in ventilation in zone 1 and a decrease in perfusion. I don't have much circulation going on there because all of my blood flow is going to be down here in zone 3. I have all this gas, all of this oxygen and carbon dioxide that's taking place up here, but all of my blood, not all, but a good majority of my blood is going to be down here in zone 3. So whenever I move on down to zone 3, if I look here, my arterial pressure is greater than my alveolar pressure. So I have more perfusion down here in zone 3 than I do ventilation in zone 3. So that leads to what we call a VQ mismatch, and we'll talk about that. But we have more circulation of blood because we have more blood available in zone 3 than we do ventilation because those alveoli are being squashed by all that extra blood. Now in zone 2, so let's look at zone 1. PA is greater than the P little a. In zone 3, your P little a is greater than your P big A. Little a being little a being arterial and big A being alveolar. Same thing up here. Big A are alveolar, little a arterial. Now when we get to zone 2, we have a lot of discrepancies because you have alveolar pressure and you have arterial pressure that kind of fluctuate. So when we look at zone 2, this is where we get so many changes in ventilation to perfusion. And this is where we start to see changes in our respiratory quotient here in zone 2. Zone 1 and zone 3, those are pretty static. They stay the same quite often, but you have a fluctuation of the arterial pressure, the alveolar pressure, which changes the amount of ventilation and perfusion that are taking place in zone 2. Moving on to bronchial circulation. Remember, this is the circulation that is going to take care of getting blood to the trachea and the conducting zones and to the outlying parenchyma. There's not a high metabolic demand when it comes to getting nutrients to those conducting zones. So the metabolic demand is relatively low. We're not getting a lot of action when it comes to the trachea and to the bronchi, and those early generations, they don't need a big supply when it comes to nutrients and blood. It only takes up about 1 to 2% of the overall cardiac output. There's not a whole lot of blood that's being sent to bronchial circulation. So we'll finish up right here with the neural control of the lungs. This is part of the peripheral nervous system that uses the autonomic and the somatic system so that pulmonary circulation can take place, so that the neural control of the lungs can take place. And what I mean by the autonomic system, this is the automatic system. This is what we use when we're not thinking about taking a breath. This is what we use when we don't think about making our heart beat. So the autonomic system is the automatic system. It innervates from the 10th cranial nerve, which is our vagus nerve, and then sends that signal down to the phrenic nerve to stimulate the diaphragm. So the autonomic system utilizes the brainstem and the 10th cranial nerve, the vagus nerve, to then innervate the diaphragm. Now, when we look at the spinal cord, this kind of stems off of the spinal cord about the 4th or 5th sympathetic ganglia. So we're looking at the 4th or 5th sympathetic ganglia. And really what we're looking at for functions here, is this is going to maintain homeostasis. So when we have patients, or when we have somebody that is short of breath, or if we were to go take a lap and go for a mile run, we would be using more cells, more skeletal muscles would be used. We're going to be burning more calories. We're going to be utilizing more cells. The more cells we use, the more oxygen they need. The more oxygen they need and the more cells that are being used, the more carbon dioxide that's being produced, the more carbon dioxide that needs to be eliminated. And the lungs are the resource, or the primary source, to eliminate that carbon dioxide. So we utilize the autonomic and the somatic system to maintain homeostasis and to help regulate the amount of carbon dioxide elimination and that takes place. The other thing is, if you have an irritant, if you have a foreign particle that's in your airway and it's irritating you, it's a stimulant, right? I can trigger myself to cough. I can stimulate myself to cough, which is utilizing that somatic system. So if I feel like there's something that is irritating my airways, I can clear that with the somatic system and not rely solely on the autonomic system. So there you have it. That is the pulmonary circulation, quick, fast, and in a hurry. So there you have it, guys. That is the pulmonary circulation, quick, fast, in a hurry. Nope. So there you have it, guys. That is the pulmonary circulation. That gives you some good insights as to what the function of pulmonary circulation is, what it does. If you have any more questions about this, Be sure to leave those in the comments. You can email me directly at jjthert@gmail.com. Be sure that you like, subscribe, hit that little notification bell if you would like to get updates automatically with the content that's coming out. Be sure that you follow me on any and all of the social medias. I'm looking forward to seeing you guys out there. Be sure that you follow me on any of the social medias. I've got Instagram, TikTok, X, LinkedIn, Facebook. You can find me on all of the platforms. And remember, you guys, we are always striving for progression. We're never going to reach perfection, and it is exciting to see. No. And remember, guys, just because something has never been done, it does not mean that it will never be done. Years ago, there was... Remember, guys, just because something hasn't been done yet doesn't mean that it will never happen. Years ago, the first person ran a 4-minute mile. That same year, 5 other people were able to run a 4-minute mile. So when we look at somebody, so when you think, I'm never going to understand these concepts, I'm never going to get this, I'm just never, like, when you get into that thought process, one of the questions that I like to ask is, what does Revan mean? What does Revan mean? Well, if you think about it, Revan is actually never spelled backwards. And just because it hasn't happened doesn't mean it hasn't happened yet. So continue to work on yourself, continue to progress. Just because you don't understand it yet doesn't mean that you're not. Means just that you don't understand it yet. So continue to fight for progression. We're never going to be perfect, but keep pushing for continual improvement. Your patients deserve it. What is up, you guys? Hey, we're going to jump into another anatomy video here. This time we're talking about the pulmonary vasculature and all of the components and the functions that it runs with. So let's jump right in to pulmonary vasculature.